If you or your child has ever been told you have mild scoliosis, you may be wondering, is this serious? Should I do something about this, or should I just wait and see what happens? The simple answer is it really depends. Every curve is different. I've worked with hundreds of families and adults facing this exact same question. So today, I want to help you get clear, specific answers on what you should do if you or someone in your family has been diagnosed with mild scoliosis. Hi, I'm Dr. Chris Goebbels, and for over a decade, I've dedicated my career to helping patients successfully manage scoliosis treatment and avoid surgery. At ScoliCare, we are world leaders in education, research, and the non-surgical treatment of scoliosis and hyperkyphosis. So let me walk you through what you need to know about mild scoliosis and what to do next. Now, if you haven't already downloaded our free ebook on how to effectively treat scoliosis and what you need to know about scoliosis, be sure to click on the link below to get your free copy. So let's start with what mild scoliosis means. Scoliosis is technically a diagnosis where the spine has a curve or lateral bending of the spine of at least 10 degrees with rotation present. And this is measured using something known as the Cobb angle of measurement. Now, scoliosis can be classified by the severity of curve. For example, if you have a curve between 10 and 25 degrees, that is considered a mild scoliosis. A curve between 25 and 40 degrees is considered a moderate scoliosis. Now, a curve over 40 degrees is considered severe scoliosis. And I would say a curve over 60 degrees is considered very severe scoliosis. Now, when it comes to determining the most appropriate and the most effective treatments for scoliosis, the size of the curve is just one of the factors that help us to determine the best treatments for each individual case. But the size of the curve doesn't tell the whole story. Let me explain. Idiopathic scoliosis most commonly develops in adolescents during the onset of growth spurts associated with puberty. Now, if we just go by recommendations from the Scoliosis Research Society, which is the international society for the surgical treatment of scoliosis, all we would look at is the size of the curve. So let's take a look at the recommendations. So the SRS says if someone has a curve that's between 10 and 25 degrees, all you would do is observation. Now, a lot of times this means watch and wait. We don't really recommend watching and waiting. Watching and waiting means you just go home, you maybe come back in a year, you see if anything changes. Where active observation is where you have regularly scheduled checkups and x-rays to see if the curve is changing. If a curve is between 25 and 40 degrees, then you would do bracing. And if the curve is over 45 degrees, then surgery is indicated. Now notice, when I went through these recommendations, I didn't even mention anything about scoliosis-specific exercise or physical therapy. They don't even bring that up in their recommendations. And that's because a lot of people in the surgical or orthopedic world are not really familiar or don't have an in-depth understanding of the different types of scoliosis-specific exercises or rehabilitation. But I'm going to tell you there's flaws in this. And I recently heard a podcast by a really well-respected surgeon and researcher in the orthopedic world, where even he was saying that in the orthopedic world, they're looking at their own recommendations and realizing they probably need to be more aggressive in treatments early on, and they probably also need to treat curves even later on that are larger before they rush into surgery. But if you only follow these recommendations, a lot of times you miss the key window of opportunity to have the most effective treatments for scoliosis. Because remember, all big curves start off as small curves. So let me show you a case of one of my patients that went through the traditional orthopedic world, and let me show you what happened to her curve when she was managed by the orthopedic recommendations or recommendations that the provider was following, which were just recommendations put forth by the Scoliosis Research Society. So let's take a look at this patient. So this patient went to a pediatrician who observed that she thought she had scoliosis. And so then she went to the orthopedic hospital here in Denver, Colorado. When she went to the first orthopedic doctor, this was a pediatric orthopedic specialist. They told her that she had a 13.7 degree scoliosis. It was not a concern. Now, she was 13 years old. She was what we consider risk 0, which means she hadn't even, a risk 0 negative, which means she hadn't even really started to hit her initial growth spurt. She was just about to hit that growth spurt. But she told her to do nothing, to come back in about 6 months and just see what happened. Well, from that time, this was in July 2020, and she came back to get checked just about 6 months later in February 21. Well, in that time frame, her curve went from 13 degrees to 23 degrees. degrees. That is a 10-degree increase in about 6 months. Now, if a curve is getting much worse than 1 degree per year, that's a pretty high indicator that this is an aggressive curve that's going to continue to progress. But even at this point, it was at 23 degrees, it was below 25. She was told there's real no need for treatment. She was a Risser Plus now, which basically tells us she was just she was just entering her growth spurts, and she was in her period where she was going to go really fast. And I'll talk more about that in a minute and how that makes it different when we're deciding what recommendations. So she was told to do nothing, and this was in February 21. Well, then she came back here in November of 23 because the pediatric doctor thought this was the concern, it's not going to get worse. Well, here her curve went from 23 to 30. And now she's much more advanced in her growth spurts, and she's later on. So her curve had progressed another 7 degrees. So she said, she's later in her growth. It's not really a concern at this point. It's probably going to stay there. She doesn't have a lot of growth left, what the professional thought, and said, it really shouldn't go. It's fine. But this is the curve that, if you know a lot about scoliosis, it probably has a pretty high risk of progression based on the size of the curve, even though she's further along in her growth at this time frame. Again, this was almost 2 years later. This was exactly 21 months from here to here. So the mom realized something was not right. And so she eventually came into our office in September 2015. So literally here about another 10 months. And at this point, her scoliosis was 45 degrees. Now at 45 degrees, she had actually reached a surgical threshold. And when the mom went back to, the pediatric orthopedist, the orthopedist said she was shocked. She couldn't believe this had happened. But someone who's really skilled in the conservative management of scoliosis, where this had progressed from here to here, that's a pretty high predictor of this is an aggressive curve and it's likely to progress. And if we would have intervened earlier, we could have had even greater outcomes. So she was actually recommended for surgery at this point. Here's what's interesting. This is actually a slide. I took a photo of this. This is a video of Children's Hospital where they're talking about scoliosis management. And what they say in this video is that wearing a brace does not make the curve smaller. And they actually tell people the goal of bracing is not to change the size of the curve. In fact, they say you cannot reduce the size of the curve. You can just try to stop or slow the progression with the hopes of preventing surgery. So they tell people all the time, you cannot change the size of the curve. But in that previous case I just went over, at this point, the mom reached out to our office, and I want to show you what's possible with the right treatments. So this was the girl when she came in to see us. Like I said, it was about 44, 45 degrees. She was Risser 3/4, which means she was already pretty far along in her growth spurts. Didn't have a ton of growth left. But this is where she was at. And a curve like this, even when they're done growing, will 100% keep progressing. Curves over 30 degrees have an increased likelihood of progressing even after skeletal maturity. Curves over 50 will 100%. But the location of the curves in the thoracolumbar, which is right here, or in the lumbar spine, also have a higher risk of progressing in adulthood after skeletal maturity. So we made her a custom Scoli brace and had her do scoliosis-specific rehabilitation, or Scoli bounce. This is her in-brace correction. You can see we got her curve from 44 degrees down to 12 degrees, and this is after wearing a brace for just 1 month. And that tells us she's an excellent candidate for treatment, and she has an excellent candidate for reduction. This was her at just 3 months after beginning treatment out of the brace, and her curve out of the brace has now reduced from 14 degrees or from 44 degrees down to 25. Almost cut that in half, and then her upper curve also reduced. So we just showed you that it's not just that curves can't be stopped, but with the right treatment at the right time, we can have great success, and many times we can actually reduce the size of the curve. And if we would have treated this person even earlier, we would have had even better outcomes. So the treatments that we follow are actually based off SOSOR, which is the International Society for Scoliosis Orthopedic and Rehabilitation Treatment, which is basically the international society that decides what are the best and most effective and most appropriate treatments for the non-surgical treatment of scoliosis. So all the treatments we do at ScoliCare follow the guidelines established by SOSOR. And the things I'm going to talk about today come from a couple different sources. One of those is a 2016 treatment guidelines put out by SOSOR. The other ones come from this paper, also a SOSOR publication. Now, what I love about both of these papers and what I love about SOSOR is it's very clear that we can't just go up just the size of the curve. We have to look at the size of the curve and how much growth they have remaining. Those things combined tell us the likelihood of the curve progressing. And the higher the risk of the curve progressing, generally the more aggressive treatments we do. But we have to look at how big the curve is and where they're at along their growth spurts to determine the likelihood of curve progressing. And we use that information to give the best treatment recommendations. Also, there's generally a scope of acceptable treatments, from anything to the bare minimal acceptable treatments to the most aggressive treatments. And within that scope, which is called evidence-based treatment, there's three things you have to consider. One, what does the science say can be effective at treating this individual case? Two, what does the patient want to do? And three, what is the doctor actually skilled at doing? So when those things overlap, there's generally a range of treatments. Now, from this paper, they actually have kind of a formula that providers can use to determine the most effective treatments based on the likelihood of progressing. And so in this, there's a formula where we're looking at the progression factor. And we can measure the size of the curve, and we can subtract it 3 times the Risser sign. The Risser sign is a sign that tells us how much more growth the individual has. If someone's Risser 0, they have a lot of growth. If they're Risser 5, they're basically done growing. And we divide that by their age. But basically it gives us the number. And as you can see, the higher risk of progression, the more aggressive the treatment, all the way from surgery to full-time bracing, to intensive rehabilitation, to outpatient scoliosis-specific physiotherapy, all these things. So more aggressive the curve is, or the more likely to progress, we may recommend different treatments. This is a great chart, and it's really critical for parents to understand because it shows us how the development of the curve changes over time. This right here, this dotted line represents spinal development. And if you look at this line right here, you'll see during juvenile years, it's basically from 3 to about 9, but basically from birth to about 5 years old, you have really rapid growth, and the rate of growth slowly decreases over time. From about 5 to about 9 or 10 until you hit puberty, the rate of growth is really steady, and actually proportionally, most of that growth actually comes in your limbs. But if you look right here, with the onset of puberty, this is when your growth just skyrockets. This is right at about Risser 0 plus. And during the first 2 years of puberty, you have your peak height velocity. So those first years of puberty, you take off extremely fast. But what also happens is proportionally, a lot of your growth happens in your spine. When you're younger, as a child, most of your growth is in your limbs. But when you hit puberty, most of the growth proportionally is actually in your spine. So right here, this is actually where the curves progress. And it's during the first 2 years is when this curve can progress really fast. And then after the first 2 years, the rate of growth starts to slow down gradually, but the curves can keep progressing. So this is really critical to understand, is based on the level of skeletal maturity and the rate of growth, along with the size of the curve, we can help determine what the most appropriate treatments are. Now you can look at the Risser sign in the pelvis, but there's other signs we can look at as far as skeletal maturity. The one I like to use the most is called the Sanders sign, where we're looking at the bones in the hand. But this can give us an idea of where someone is in their growth cycle, their rate of growth, and also that helps us predict how progressive the curve is and the likelihood of the curve progress. But to give you some examples, let me kind of dive in to some different treatment scenarios based on how much growth is left and the size of the curve. So let's take a look at a juvenile. A juvenile is typically between 4, we can say between 3 and 9 years old, but it's basically a child that's growing, not a toddler, not a teenager. So let's say we have a juvenile that comes in and they have a curve that's less than 15 degrees. Well, most of the time what we're going to do is we're just going to do observation, probably do a checkup every 3 to 6 months, probably a new x-ray at least every 6 months to see if the curve is getting worse. I had a patient just like this. They came in, their curve was about 14 degrees. We're just doing observation. We'll have them come back in 6 months. We're going to check. We're going to see if that curve is staying where it is or if the curve is progressing. Now, if that curve is between 15 to 25 degrees, then we have some different options. At that point in time, we could do part-time bracing or a brace just worn at night. That's one theory, because the curve is probably not as progressive. You can also do scoliosis-specific exercise. We do what's called ScoliBalance. We don't start doing scoliosis-specific exercise until probably at the earliest 8 years old, but we also look at the maturity of the patient and what they're able to do. If someone's more advanced, they have more coordination, and they can do the exercises effectively, they could possibly start around 8 years old. But someone that develops slower, they don't have the coordination, if they can't do the corrective exercises, then it doesn't make sense to start. So exercise may be an option. Now, when you have an early onset scoliosis, like an infant or a juvenile, those curves are generally more aggressive. The earlier the curve starts, generally the more aggressive they are. In fact, I read one paper that said early onset scoliosis patients have a 50% likelihood of them having surgery. Early onset scoliosis is basically before the age of 10 as an infant or a juvenile. So we used to know these people have a long treatment window, and so we would try to be more conservative with the brace time because we didn't want to get them burnt out. But more recently, we're kind of shifting our thinking because we know kids when they're younger, they're very kind of pliable and we can make really impressive changes. So what we'll do a lot of times now is treat a juvenile with the same intensity as an adolescent, and we'll do bracing full time. Because with full-time bracing, a lot of times in juveniles, get that curve really small. And if we get the curve small enough, we can actually take a break in bracing and then observe them, knowing with the onset of puberty, we will likely have to start bracing again. However, sometimes those curves stay small and we can take a permanent break in the bracing. So we actually prefer when the curves are in this degree to probably brace full time, get that curve super small, and then have the option to take a break in bracing, or what we would call, or basically take a recess from treatment for a while we just observe. Now if a curve is between 25 and 40 degrees, that's definitely when full-time bracing is going to be needed. Even if it's a juvenile, those curves are getting big and the bones are growing to form pretty rapidly. And then scoliosis specific exercise as long as the patient is effectively able to do those. And over 45 degrees, they may become a candidate for surgery. Let's look at an adolescent with a curve less than 15 degrees. This is typically observation. Now, if someone is early on in growth, like wrists are 0 and they're just taking off, we're possibly going to be doing scoliosis specific exercises or potentially doing bracing or part-time bracing. But if someone has a 15-degree curve and their wrists are 3 or 4, we're likely not doing any treatment because they're already further along in their growth and we know the curve is not as progressive. So observation, scoliosis specific exercise, possible part-time bracing, potentially full-time if their wrists are 0, but it depends on where they are. First, the parent's choice. Also, it depends on where they're at with their growth, because that's going to tell us the likelihood of the curve progressing. Now let's take an adolescent that's between 15 and 25 degrees. Observation. Generally, if they're older adolescent, maybe wrists are 3 or 4, that's when possibly observation. If they are anywhere below wrists are 2, we're 100% going to be doing at least scoliosis specific exercises. And even wrists are 3 or 4, we're probably doing at least scoliosis specific exercise. And then intensive scoliosis rehabilitation. If we have someone that is wrists are 20, 25, and they are like wrists are 0 plus, and we already have a big curve, and if the curve is also stiff, we're going to potentially do more intense treatment like daily for 1 or 2 weeks in the beginning to help us increase flexibility and reduce that curve while we're also introducing bracing. So part-time bracing along with scoliosis exercise could be a thing, and potentially even full-time. So how would we determine if we're doing scoliosis specific exercises, intensive, part-time, or bracing? There's a few things. One, where they're at in the growth. The more growth they have, the higher the likelihood of the curve progressing. Also, if the curve is stiffer, we generally will do possibly more intense treatment to get some mobility in the spine. So when we do add bracing or when a brace arrives, we have a better likelihood of reducing that curve. Plus, we also have to look at what the patient's goals are. You know, if someone just really doesn't want to do treatment, you're probably going to be more conservative. If someone wants to do everything they can possibly do to minimize this, you can be more aggressive. Now, I actually used to be more conservative in my recommendations, but I remember one day a patient asked me, well, what would you do if it's your child? And for me, being a specialist and knowing what could happen, I 100% was going to be as aggressive as possible. So I'm always, sure to let patients know these are your range of treatment options. And if you want to know what I would do as a parent, a lot of times I'm going to err on the side of being the most aggressive, but you have generally more than one treatment option that you can choose from, and any of those could be potentially right treatments. So how about 25 to 40 degrees? Observation is probably out of the window at this point unless you're just about done growing, and even then it's maybe if it's 25 or 30 and you're about done growing. Otherwise, you're likely going to have to do something. Scoliosis specific exercise is an option, but generally here we're going to be doing scoliosis exercise along with bracing. Intensive scoliosis rehab is a potential option, especially if it's a bigger curve like around 45 degrees and there's a lot of growth left. We're probably going to be doing intensive rehab. Part-time bracing is going to be out of the window at this time for most cases, and we're likely doing full-time bracing. So in a scenario like this, it also depends where they are with the growth, but we're likely doing at least scoliosis specific exercise or potentially intensive scoliosis rehabilitation, at least 1 to 2 times a day for 1 to 2 weeks, and likely full-time bracing. So those are just some ideas, and as you can see, the higher the likelihood of the curve progressing, the more aggressive, generally the more aggressive the treatment. And then curves 45 to 60 degrees. Now here's what's interesting. At 45 degrees, someone becomes a candidate for treatment. It doesn't mean they have to, because we do have evidence to support treatments up to 60 degrees with conservative treatments. So if someone has met surgical thresholds and the curves between 45 and 60 degrees, and they absolutely refuse surgery, and they sign a waiver, we can treat these people in many cases. We can do scoliosis-specific exercises done in the office at home. We can do full-time bracing and possibly an intensive in the beginning of treatment. Beyond 60 degrees, we don't really have any evidence to show we can effectively treat those, and someone's likely going to have surgery. Definitely need to be doing a surgical consultation even after 45 degrees. So surgery is an option. Now, what about adults? Adults is pretty simple. With adults, you have treatment options of scoliosis-specific exercise for mild curves even larger, and we can do bracing, and we can do surgery. Those are the 3 treatment options that have been shown effective in treating adult scoliosis. But the goal in treating adults is different. The goal in treating adults is not to reduce the size of the curves. Now, with that being said, there are many instances in younger adults that have more flexible curves where we reduce the postural collapse. Part of the scoliosis is a bony deformity. We cannot change that. But someone can have a big shift in their spine from the side. Postural issues can generally be improved in younger, more flexible adults. But the primary goal is to stop the curve where it is or dramatically slow the progression and reduce pain and enhance quality of life. So the recommendations from SORT in any adolescent or an adult where they're in chronic pain, when indicated, bracing is a potential treatment option. And this is generally not well known for adults in the orthopedic world. A lot of the research on bracing adults and treating adults with scoliosis-specific exercise, it's in older adults that have more severe, more painful curves. But even in those research papers where they show the effectiveness of treating adults with larger, more severe curves, they say in many of the papers, although we treated people when they were older and we were still effective, we likely would have been better off treating people when they were younger and their curves were more flexible and less stiff and the curves were smaller, because all big curves start off as small curves. And when we treat small curves in adults, even mild scoliosis, we're actually changing the natural history of progression. So we're not always trying to make the curve smaller, but a lot of times we can predict where the curve is going to go. And if we know a curve has a high risk of progression, it's best to actually actively take care of it and effectively manage it, even when the curve is small. Now, when we look at adults, you could have 2 things. You could have someone that had a curve when they were smaller, an adolescent idiopathic curve that they still have in adulthood, and now it's progressing and become more degenerative. Or you could have a new scoliosis called a de novo scoliosis that develops in adulthood. These de novo scoliosis, which is a scoliosis that develops in adulthood, typically happens in women around the onset of menopause, and in men generally later, like 60, 70 years old. But there are 10 things that I have observed in the scientific literature and with actively treating patients, 10 different things that I look for that gives me an idea of the likelihood of a curve progressing. So let me go through those 10 signs of potential curve progression. So factors that influence curve progression. 1, the size of the curve. As I said earlier, a curve over 30 degrees has an increased likelihood of progressing, impacting quality of life, and causing pain in adulthood. A curve over 50 degrees will 100% continue to progress in adulthood. It's most certain going to cause pain, impact overall health, quality of life, and probably lead to debilitating pain if untreated. So the size of the curve is one thing we look at. If you have a lateral listhesis of over 5 or 6 millimeters, a lateral listhesis, if you look real close right here, the edge of these bones are all lined up, but this one shifts laterally. This is the edge of this bone. This is this one. This one shifts laterally compared to this one. And when a bone shifts laterally and you get a lateral listhesis, that tells us that the spine is unstable because the ligaments hold bones together. The ligaments can no longer hold that. They've lost their structural integrity, and that's a curve that's likely to progress. The location of a curve. When you're an adolescent and growing, curves in the thoracic spine have a higher risk of progression, a higher rate of progression. But when you're done growing, curves higher in the spine are generally more stable because the rib cage and all this bony structure kind of stabilize them. You don't have that in the lower spine. So in an adult, if you have a curve in the thoracolumbar, which is this region right in here, or the lumbar spine, curves in the lower part of the spine, they have a higher risk of progressing in adulthood when you're done growing. Sacral obliquity. This is your sacral bone right here where your spine sits on. Obliquity means an unleveling or unsquare. If you have an unlevel sacrum, which could be because the bone is misshaped, or you may have a short leg on one side. Like if you look at this patient, this leg's a little bit shorter. If you look close, you can see the sacrum actually tilts this way, it's lower. When you have the unlevel surface, that increases the likelihood of curve progressing in adulthood. L3, L4 end plate angles. So this is L3, L4. It's not really a scenario in this one, but if these vertebrae are tilted a lot, meaning they have a steep oblique angle, meaning if you looked at this one, if the edge of this vertebrae or this vertebrae were really steep, that's a high predictor of curve progressing. L5 intercrest line. So L5 vertebrae, which is right here, typically sits below the iliac crest. So if I draw a line straight across these iliac crests, this is typically below that. If this line drawn across intersects L5, which tells us the spine sits higher in the pelvis, that means the spine is more unstable, higher risk of progression. Here's a way to think about this. If you take someone who's kind of short and wide and stout, they're gonna be more stable in compared to someone that's very long and thin. So the higher the spine sits in the pelvis, the more unstable it is, the higher risk of a curve progressing. The lower the spine sits in the pelvis, the more stable it generally is, and the lower risk of curve progression. Coronal and sagittal balance. Coronal imbalance is normally from the front. Your upper thoracic spine, cervical spine should sit right over the center of your sacrum. So on here, if I draw a line straight up, this should be here. Here you can see the person's spine is actually shifted to the line. They're out of balance. That has an increased risk of curve progression. Same thing here. This is the upper thoracic spine. If I draw a line straight down, that should be lined up over here. If you look at this, you can see the person's body is really leaning forward. So they are out of sagittal balance. So if you're shifted over to the side here, or you're leaning forward from the side, that increases your likelihood of a curve progressing in adulthood. Thoracolumbar kyphosis. If you have a reversal of the normal curve of the spine from the side here, or you lose the curve in your lumbar spine from the side, like if you don't have a normal curve here, then you have an increased chance of that curve progressing. You can actually click on a link here. I'll put it right here up in the corner in this end card, and that can take you to a video if you really want to know more about the likelihood or risk of curve progressing in adults. This video right here dives into that in detail, and I show some very specific slides on that. Spinal rotation. This is the apex of the curve. There's ways we can actually measure how much this is rotated, and the higher percent or the higher amount of rotation on there, the higher risk of those curves progressing in adulthood. So those are 9 of those things, and the other thing we would look at is just degenerative collapse. When you see big wedging in the disc and those things, that also increases the risk of these progression. Now, if you're watching these and you have scoliosis and you're wondering, my curve may be mild, maybe more severe, or maybe I'm not sure, but either way, you're not sure how severe your curve is or how likely it is to progress, or maybe you're just really wanting to know, like, what are the treatment options for me? Click on the link below and request a free discovery call. That discovery call is a chance to talk with me one-on-one for 15 minutes, and I can review your case. So ideally, we have you send us your x-rays so I can look at those, and I'll review your case and your scoliosis. I'll let you know how severe the curve is, the likelihood of your curve progressing, and what the most effective treatment options are. Now, if you're a parent and you have an adolescent and you want to learn more about the likelihood of curves progressing and how that could impact treatments, click on the link and watch our next video to learn more.